Welcome back to the YouTube channel of Dermatomyositis. In the case discussion series, today we will be discussing a case of dermatomyositis. Now, dermatomyositis is a connective tissue disorder, and the connective tissue disorders they have a lot of cutaneous manifestations. That is why it is very important for the dermatologist to know about the cutaneous manifestations of these connective tissue disorders, as these patients can directly visit to a dermatologist. But before taking up a detailed discussion of a case of dermatomyositis, I would like to inform you that we take detailed lectures on important topics in dermatology. And to know more about these lectures, you can visit www.dermacoaching.org, or you can write an email to us on DERM, that is dermniharikajha@gmail.com. Coming back to the case discussion, this case is about a 29-year-old female, and she presented to the OPD with complaints of itchy lesions over the face, scalp, and upper back, and the duration of the same was around 1 month. She complained of extreme photosensitivity. There was a previous issue of lordosis, and she said that because of lordosis, she finds it difficult, the patient finds it difficult to get her from the bed. The patient was already under treatment from some other dermatologist, and these patients were previously diagnosed as papular urticaria, for which the patient was maintained on deflazacort for almost about 3 weeks, but the response to the same was inadequate. So when she presented to me on observation, I found on examination there were well-defined hyperpigmented macules with scaling, and they were predominantly present over the face, neck, and the upper chest. Apart from that, crusted flowers and tiny erosions were present over the chest and the neck. Multiple tiny vesicles were present over the upper back. Scalp showed scaly plaques and erosions, and there was some amount of pus discharge as well. And palm, soles, and oral cavity, they were perfectly fine. They were not involved. So these are the photographs of the same. So you can see that there are few tiny vesicles. Some of them have already crusted. This is the photograph of the chest, and multiple such tiny vesicles were present over the upper back. This is the photograph of the scalp where scaly plaques are present, and the scales are, somewhat of white color, and these are present over the scalp. If you can see over here, there is some amount of pus discharge as well. Now, because of this history, I was very clear in my mind that this is a case of pemphigus foliation, because all the seborrheic sites were involved. Issue of photosensitivity was present. Seborrheic dermatitis like scaling was present over the scalp, and I was pretty sure that this is a case of pemphigus foliation. But because the vesicles were very tiny, present predominantly over the upper back as well, there was some confusion that it might be a case of dermatomyositis. Irrespective, I asked the patient to get a biopsy done so that I can send the sample for histopathological examination and immunofluorescence. But to my surprise, DIF was negative. Neither IgG was present, nor IgA was present. And the histopathological examination showed the features of pleura from the lesion which was taken from the upper back, and the lesion from the scalp. Found the features of the same were found to be the features of the same were suggestive of pityriasis lichenoides chronica. So I was not pretty much convinced if this is actually a case of pleura and PLC, because the features were somewhat different from a typical case of pleura PLC. So I decided to keep the patient under observation, and till that time I was giving symptomatic treatment to the patient, and I was thinking what else the diagnosis could be, if it is actually pleura or not. Then certain further advancements took place with this case. What happened was that patient developed high-grade fever, which was associated with chills and rigor. And that is why I admitted the patient. I thought that the fever and the chills and rigor is because of the pus discharge which was present over the scalp. So I admitted the patient to start her on IV antibiotics along with paracetamol and to maintain proper hydration. During her course of stay in the hospital, she developed oral ulcers, and there was sudden onset of massive hair fall. Patient developed lilac-colored discoloration around the eyes. Now, from here, from this development onwards, I started thinking that this might be a case of connective tissue disorder because she previously had photosensitivity, extreme photosensitivity. Now she had started developing extreme hair fall. Then she started developing oral ulcers, and now there was lilac or violaceous colored discoloration around the eyes. I started thinking that this might be a case of dermatomyositis because this is somewhat the discoloration around the eyes was very much typical of that of a heliotrope rash. Then hyperpigmented scaly macular rash started developing over the chest, neck, and the upper back, which was consistent with the shawl sign and the V-neck sign. The scaly papules, which were hyperpigmented, developed over the dorsum of the fingers, which could have been the Godwin papules. The old vesicles now have started subsiding, and they were subsiding with poikilodermatous changes. Patient complained of extreme dryness in the mouth. Now, their features were somewhat, overlapping. Oral ulcers, extreme hair fall, photosensitivity were more in the favor of SLE. Then photosensitivity and hair fall can be seen in multiple connective tissue disorders. So I was thinking that apart from SLE, I should consider other diagnoses, particularly dermatomyositis, because the patient had developed very heliotrope rash, then V-neck sign and shawl sign. And apart from that, there were some lesions over the dorsum of the finger, which were suggestive of Godwin's papule. But the thighs were totally fine, and the previous lesions, they were subsiding with poikilodermatous changes. But this new complaint was somewhat suggestive of Jogren syndrome because the patient kept on complaining that even after drinking a lot of water, she still used to feel dryness in her mouth. So this feature is somewhat similar to the complaint which we usually get in patients of Jogren syndrome, which is xerophobia. Also, I started thinking if the previous history of lordosis is actually proximal muscle weakness, that is why is she developing difficulty in getting up from bed. And these are the features that the patient develops. So you can see that the periorbital rash or discoloration is actually not typically hyperpigmented. It is somewhat violaceous in color. So there is a violaceous discoloration in the periorbital region, which was heliotrope rash. Then you can see that there are poikilodermatous changes in the lesions which have started subsiding now. They're subsiding with poikilodermatous changes. This is query Godwin papules. I'm still not very much convinced if this is actually Godwin's papules, but yeah, they were present over the dorsum of the hand. They were hyperpigmented and somewhat scaly in nature. You can see a typical V-neck sign over here. Erythematoid to hyperpigmented scaly macules present over the upper chest in a V-neck fashion, and similarly, similar kind of rash was present over the upper back, which was consistent with shawl sign. Okay. Positive history now was that there is extreme photosensitivity, there is very proximal muscle weakness, heliotrope rash, shawl sign and V-neck sign, and Godwin's papule, poikilodermatous changes, and excessive hair fall. So I decided to get the whole autoimmune panel done and the myositis panel done. In the autoimmune panel, ANA, DHDNA, and anti-histamine antibodies, all these things were negative. In the myositis panel, two things were positive. I'm going to focus only on the positive things. First thing was anti-Rho antibodies, which are present in the myositis, scleroderma patients, and SLE patients. Okay. And the second thing was anti-Rho antibodies, particularly the anti-Rho 52 antibodies were positive. All the anti-Rho antibodies are more commonly present in the Jogren syndrome patients and can be also seen in patients of dermatomyositis and polymyositis. And this was 3+ positive. So now it was confirmed that it is either a patient of mixed connective tissue disorder or dermatomyositis, but I was more convinced for the feature of dermatomyositis because the features were more inconsistent with the dermatomyositis case. Other reports were negative, but there was hypoconcymetemia, which was present. Antiphospholipid antibody, both IgG and IgM, they were negative. They were within normal limits, and there was hypocomplementemia C3, which was also not present. So hence, I came to the conclusion that this is a patient of dermatomyositis. I started the patient on a very good sunscreen and treated the cutaneous rash using topical corticosteroids and tacrolimus. I started the patient on decreasing dose or tapering dose of oral corticosteroids, and I referred the patient to a rheumatologist. So this was a very interesting case in which the feature developed over a period of time, and that is why it is not always possible for a dermatologist to make the diagnosis in the very first visit of the patient. Sometimes it can take more than one or two visits from the patient side so that the dermatologist can actually reach to the correct diagnosis, particularly in complex cases like these. So although these cases are rare, but they can directly present to a dermatologist, and that is why I thought of taking up this case for the next case discussion lecture. Okay, I hope you found today's video interesting, and I hope it was of some use. Take care. Have a nice day.